virus and opportunistic infections. Sorry. It remains an important conference for researchers, for advocates, policymakers, and I think this year's conference has once again provided a platform for the latest scientific advancements in biomedical prevention, HIV cure, just among others. And so today we do have an opportunity to just reflect on the key science and some of the evidence that is coming out, but also to talk about highlights so far. We'll have an opportunity to look forward to the day. This is the last day, and just to check with our panelists on what they are looking forward to see today. So our panelists will be sharing their perspectives, as I've mentioned, and we do have a stellar panel. I'll ask them to introduce themselves because you would want to know them. And so I'll ask them to actually come in and just introduce themselves. As Jim said, we would really love you to engage as much as you can. The chat box, if you want to speak, you can raise your hand and I'll call on you so that you can just come in and talk. But at this moment, I would like to ask Natasha to come in and just introduce herself. And after that, we'll just quickly go around so that you know who is in the room with us and who we're having the conversation with. Natasha, over to you. Natasha, are you on mute? I'm not sure if we are able to hear Natasha, but it's...
No, we can't. I think she's on mute.
I can't hear Natasha.
She's on mute.
So whilst we're sorting out Natasha, maybe we can move on to Moses Supercharger. Do the intro.
Good morning, ladies and gentlemen. I'm called Moses Supercharger. Person open living with HIV since 1994 in Uganda. I head a community-based organization called Jabasa, which is Joint Adherent Brothers and Sisters Against AIDS. I'm one AVAC Alumni Fellow 2017, and I'm happy to be one of those people who are going to discuss highlights of CROI. Thank you.
Thank you, Supercharger. Carlos, over to you.
Yes, good morning, everybody. My name is Carlos Del Rio. I'm an HIV researcher and also a physician, and I'm a member of the program committee for CROI, and I'm really excited to be here this morning.
Thank you so much for joining us. Christina, over to you.
Hi, everyone. I'm Christina Farr. I'm an assistant professor in the Center for Global Health and Diseases at Case Western Reserve University in Cleveland. And I study host microbe interactions that are important for women's reproductive health with an interest in HIV prevention, innate immunity, the microbiome in cis and trans women.
Looking forward to hear from your perspectives as well. I'm not sure if Natasha, if you're back, can you just try to introduce yourself?
I am back, Grace. Are you able to hear me now?
Totally. Awesome.
Okay. I am so sorry about that. I'm not sure what's going on with my laptop, so I had to log back on using my phone, but I hope I'm visible and audible enough. So good morning to everyone on the call. Good morning, good afternoon, good evening, depending on where you're joining us from. My name is Natasha Mwila from Lusaka, Zambia. I work for the Network of Zambian People Living with HIV and AIDS, that's NZP+, as an Advocacy Information and Research Officer. I am also the 2022 Fellow, AVAC Fellow, and the CROI 2024 Community Scholar. So I'm super excited to be part of this panel. And this being my first time, I'm just honored. And thank you to Jim and team for giving me this opportunity to be part of this panel. So over to you, Grace. Thank you.
Awesome. I think we'll be coming back to you. You just said you are a community educator, and this is your first CROI. I just wanted to get your reflection and perspectives in terms of what has been some of the groundbreaking science that you've seen at CROI 2024. Is there anything that has stood out for you and your experience generally with CROI 2024?
Yeah, no, of course. So my advocacy work back home in Zambia is more focused on advocating for the introduction of new biomedical HIV prevention methods. So having to come here, what really stood out for me was one of the sessions yesterday, and this was focused on leaning into the success of biomedical HIV prevention. And there was a lot of findings, there was a lot of insights that were coming out from these presentations. And one in particular, I will point out, there was a presentation done by Frank, I believe, and this was a randomized search trial that was talking about the dynamic of choice. And from the findings, what was emphasized was the importance of having more HIV prevention methods to be used in the community. And what really stood out also, there's always this talks around how one product is superior than the other. But looking at the findings in terms of the people that were enrolled, about an equal proportion of participants either decided to or preferred to go for Cabernet or decided to go for oral prep, So that only shows to say that we need a lot more options in our communities, especially in the sub-Saharan Africa countries, because that's where the HIV burden is quite high. So we need to have, a lot of governments need to introduce and approve all of these HIV biomedical prevention methods that are being introduced and recommended. The importance of that is because I, Natasha, might want to use Cabernet, but Grace might want to use the ring. And also another fun fact that I got to really love, the findings on was another presentation that was being talked about on the ring, that it is quite safe. A lot of conversations around the ring is that, well, it's not safe. There's the efficacy aspect of it. But a presentation that was made yesterday actually showed that it is safe, and not only safe in just women, but pregnant women. And during the trial, there was no seroconversion, which is very encouraging. So to me, having to come here and see that and experience that and gain that knowledge, it's quite encouraging to go back as an advocate, and inform the community and the government and policymakers on how there's need to introduce these HIV biomedical prevention methods. And also just to add, I had the opportunity to also go on a poster walk, and there were a lot of good findings in line with treatment and PrEP, and just also STI in general. So I just wanted to also add that having to see all the research that is being done and the amazing findings that are coming out, yet a lot of people in the community do not have access to these products. I come from Zambia, and recently the Cabernet was approved and there's an implementation science going on, but no any other African country is going to have the Cabernet anytime soon. And not just Cabernet for treatment, but also, for prevention. There's also, products for treatment that are not being accessed in sub-Saharan Africa, where the burden is quite high. So I'm here and I'm hearing all this great information, but again, I'm getting frustrated because, when are we going to have access to these products? What role are we playing as advocates, as scientists, as government officials to ensure that the community have access to these products? I think being here is making me think a little bit bigger than just going back home and saying, well, there's the ring, we have the ring, it's safe, we have Cabernet, it's highly effective. There's a treatment, an injection, injectable for treatment that is being accessed in America, but we don't know when we'll have it. So it makes me think, what other ways can I play a part in to ensure that, there's high access to this product? So I will throw it back to you, Grace, and hopefully come back around. But those have been my perspectives and my experience. There's a lot more, but I will give chance to the other speakers.
Thank you so much, Natasha. That was very insightful. I'll move quickly to our next panelist. I would like to request that, if possible, let's keep it as short as possible. We do have so many questions. Don't worry, no harm made. Natasha, it was lovely hearing from you. But I want to go to Carlos and hear your reflections. You are the person behind some of this research. What's been big for you in this conference? And was there anything surprising from the evidence that has been coming out?
Well, it's not necessarily surprising, but what you see is that that research advances and it builds on prior research, right? And some of the most exciting things, a lot of stuff was presented on PrEP. We're learning more, not only as Natasha said, choices makes a big difference. And I think one of the things that's going to be interesting when I think about Sub-Saharan Africa, for example, I'm the chair of the PEPFAR Scientific Advisory Committee, and a lot of the gains in treatment have been by having a public health approach. We put everybody in the same treatment, DTL, same treatment, one approach, simple, has allowed to get 25 million people on therapy. Well, now when we go to prevention, we're saying exactly the opposite. We're saying, well, we need to give people options, right? And that, from a public health perspective, is really hard. We're going to have to tell programs how to go from going from one approach to now going to multiple approach. Is not impossible, but it's just a very different change of approach. And I think it's going to require not only political will, but it's going to require imagination and how to deliver services. And, I think it's going to be critical to have the community involved in designing those approaches. And how do we make choice available? How do we make it easy? How do we implement this? Some of the most exciting things I think are going to be presented today. There's a late abstract session today. And in that late abstract session, the results of the Latitude study are going to be presented. And the Latitude study was a study from the ACTG in which they used, cabotegravir rilpivirine, the injectable, for treatment in people who had not been able to be on oral therapy, who had been, had problems with adherence, etc. And that's not what the drug is approved to do. Currently, the approval is to use it in people who are already suppressed, doing well. But I've always said the people for which the drug is approved is not the people that need it the most. The people that need it the most are those that are not able to be taking pills. If you're able to take pills and you're doing fine, getting an injectable is a nice convenience, but it's not necessary. But if you're not able to take pills for whatever reason, the injectable is a new opportunity, yet that's not what the drug is approved to do. And what the study showed is that the injectable worked in people that were not virally suppressed, and that it gave very good results, and that actually provided the virologic suppression above those that stayed or they tried to get on oral therapy. So that's incredibly exciting. I would encourage everybody to look at that abstract, and I'm looking forward to that. Over.
Thank you so much. I think we'll come back to you with a few follow-up questions, but let me move quickly to Christina to also just hear your perspectives.
So this is the first CROI that I've had the opportunity to attend in person. So I've been having a really great time going to all the talks and seeing the posters and talking with everyone. And what really stood out to me was Dr. Nellie Mugo's plenary on Monday about HPV elimination and the associations between HPV and HIV, particularly in women living with HIV. We have higher rates in HPV, and that if we can reduce HPV acquisition, it may also lead to a subsequent reduction in HIV acquisition, and then how we can actually implement the strategies that we know work for HPV prevention, like the vaccine and testing in some of the low resource settings where things aren't as easy sometimes as they are here in the US.
Thank you so much, Christina. So I know there've been big conversations, vaccine, cure, and as I'm moving towards Supercharger, I know you're a cure advocate, and this is something that you've always been on the lookout for. Is there anything that was special for you in terms of HIV cure? Are there any advancements we should be looking out for? Even today, are there any sessions that you'd want to recommend for people who are on the call?
Thank you so much, Grace. There were several sessions, few sessions around HIV cure. Most of the sessions to do with cure happened today. We have a session about the strategies to cure HIV. We are anxiously expecting results from P1115, a study which is trying to cure children of HIV, and they are entering a phase of putting them off treatment. So we are hearing results today to know what's going on. But there were like 8 highlights which really struck me, and basically not to do with cure. There is this large clinical study conducted in Uganda, South Africa, and Zimbabwe, managed by MTN and funded by NIH. which talked about the monthly dapivirine vaginal ring and oral prep, which showed really good results that it can prevent HIV among cisgender women who started to use one of the study products in their second trimester of pregnancy. I found that really very exciting. Some of the results in this study show that actually 95% of deliveries were at term, 4% were preterm with congenital anomalies, and 1 miscarriage happened in this study. Another exciting lesson to learn is about this silent killer called cytomegalovirus. You all heard about it, abbreviated as CMV. On Tuesday, we had another great presentation, a study codenamed A5383, trying to suppress this CMV virus using a drug called letermovir in treated HIV folks. CMV virus is a chronic and usually asymptomatic virus. 60% of adults have this virus, but they don't know. That's really very scary. And more scary, 95% of people living with HIV have this virus. So CMV virus can cause immune response, including inflammation. It's really very dangerous. This study really showed that letermovir, this virus is really doing very well. It shows a response on inflammation pathways, including interleukin 1B and interleukin 6. As a person who has been openly living with HIV, I can't skip treatment. There was an amazing data around a new integrase inhibitor called GS1720. It's in phase 1B. They're trying to study this new oral integrase inhibitor, which is showing really good result that it's safe and well tolerated by people living with HIV. It's taken once a week, which is really very exciting. And as we consider choice, because we already have integrase inhibitors, but you find that some folks can't use them. They can, so you need more integrase long-acting therapy so that you can provide more choice for people living with HIV. You already know that we have a product which is being tested called lenapacavir, which is combined with lilpivirine. But of course, some people can't use that combination. The producers of this product have brought another combination of lenapacavir, adding it with a broadly neutralizing antibody. And the data show that actually it's well tolerated, virus sensitivity is really high, and it can maintain virus suppression for 6 months. I really have a lot. With the cure, I got some disappointment.
Sorry, Moses. I'll come back to you. I know there's so much that we want to hear from you, not to catch you, but I'm going to come back to you quite soon. I'm seeing hands and I'm seeing questions in the chat box, and I want us to, I'll come back to you. So just, yeah. There's a question that was asked, I think, a few minutes back from Kay. And is asking Carlos specifically about the drug that we're talking about. Maybe you could respond to that, and then I'll go to Michael to also speak. But I'll come back to you, Supercharger. Just hold on for me.
Sure.
Yes, the drug I was talking about, the one that is going to be in the study, is the injectable cabotegravir rilpivirine, right? Is long-acting injectable, which is now approved for treatment of persons living with HIV and produces good response. The issue is that, you know, this drug was tested and was only approved in people who are virally suppressed on doing well on therapy, and then they're switched to this regimen injectables that usually are giving every month or every other month, every 2 months. What this new study did is it showed that you can give them in people who are not virally suppressed. So in other words, as an option for people who cannot take oral medicines. The other thing that remind me though is that I think we're entering the era of injectables. I think we're entering the era of long-acting agents, subcutaneous drugs, and other drugs. And today there's going to be Charlie Flexner is giving a plenary. One of the plenaries today is precisely on the of this new agents, long-acting agents. And I can dream about a future in which your HIV treatment will be. I mean, ideally, I want to dream about a future with no HIV, or we can cure HIV. But unfortunately, so far, we don't have a vaccine anytime soon, and we don't have a cure anytime soon. So, but could it be possible that in the future we could have if somebody is diagnosed with HIV, you can give an injection or give a subcutaneous drug, and that will be there for 6 months or a year. You don't need to take it every day. So I think this is going to change dramatically the amount of people that can remain virally suppressed and that don't need to be taking pills every day, which we know causes a lot of, for a lot of people, it's complicated, right? Yesterday, we had a session talking about HIV in immigrants and refugees. If you don't have a home, if you don't have where to store your medications, it's really hard to be taking pills. If you're moving from one place to another, it's really hard to be taking pills. But if you're giving an injectable that lasts for 6 months, then that's not a problem. So I'm very, very excited about entering this new era of injectables, both for treatment and prevention. Over.
Thank you so much. Just to say, we are noting all the comments and the questions. We'll be coming to you as much as we can, but we also want to allow those who want to speak live on video to raise their hands. So I'll go to Michael to come in, and then we'll move from there.
Thank you. I just wanted to ask about something that was noticeably different this year, which was that the CROI site where they usually post the talks, they haven't posted any talks from 2024 yet. And it used to be that those things were coming out sometimes same day or the next day. And I could follow along when I couldn't attend the conference myself. I could basically check the talks out for myself. I feel like this year I'm sort of dependent upon third parties to get the news out, and they're only telling me about the news that they are excited about or that they were involved in. And so it feels like I'm really ignorant this year of what has been talked out about a CROI. And for people who teach the community the science, the people who are teaching their own communities the science, this is a real disservice. And I was wondering if there's a way that we can maybe get that changed back, or maybe come up with a new way, a third way yet, that's making the science more accessible so it doesn't feel so siloed and separated from the community and the public.
I think very important input. I would like to ask either Jim or Carlos to respond to that, and then we'll go to one comment in the chat box as well.
Well, Jim, you want to start? We're happy to start.
I will turn it over to you quickly. I think those are fair comments, Michael, and important feedback. And as members of the planning committee, I think Carlos, myself, and Grace can make sure that this feedback is brought to the committee. Tonight there's a dinner for all the planners, and we debrief on everything that's happened at CROI, the good and the things that we want to improve. And so I think your comments are well taken, and they'll be pushed forward.
Yeah,
Carlos.
I agree 100% with Jim. I think this is I don't know why this happened. I don't know. It took me by surprise. And as Jim says, I think it's valuable feedback. And I think it's really important that also we'll provide this feedback coming from the community, right? Because at the end of the day, again, I think CROI is a very different meeting than many other scientific meetings because an HIV community has been, hand in hand with the scientists, and we work together, and we collaborate. We listen to each other. We may not like what one or the other says, but at the end of the day, that's how the science has advanced in HIV. It's because community has worked together with scientists and with industry to advance the field. So communication and sharing of information is critical, and we will make sure that message gets across.
Great. There was a question, I think an important question in the chat box that I would want to respond to. And just to say again, if you'd want to come and speak on camera, would really love to see your faces. But there's a question around presentation and abstracts or posters. And I think I would like to take that one to Christina to weigh in. Posters around aging and HIV mechanisms. Were there any of the posters or issues around comorbidities? Were there any posters around that?
Yeah, there's quite a few posters on comorbidities, on aging with HIV. There's actually a themed discussion yesterday about inflammation and immune activation in people during with long-term ART usage that I found really interesting. They were looking at people who had been taking ART for several years, with some had low-level viremia or detectable P24 levels, and looking at their T cells to see they were finding that they usually were increased activation, so that can lead to the chronic inflammation, but they also were functionally exhausted, so they're not quite working the way that they're intended to. So I found that session really interesting yesterday.
Thank you. There's a hand from Axel. I hope I'm pronouncing that right. Over to you.
Yes, it's right. But it was me inserting this question about, let's say, shortly, the mechanisms of aging and how to prevent, because we know we are aging more quickly and have more comorbidities as all the persons living with HIV. But I would like to say also that I agree with the previous comment that a lot of persons living with HIV in the community cannot attend CROI. We don't have even a budget to go online. And I'm also a scientist. It's not because you're a person living with HIV that you can have other backgrounds. And I'm eager really to get some more feedback. For example, in this field of what are new evolutions to decrease chronic inflammation, prevent chronic inflammation, senescence, and so on, because it's very great to see new developments in drugs, like injectables. That's one field. But as we know, the population is aging, and we have to think beyond the classical HIV drugs. And this is somewhat, I miss the focus here. Maybe there is a lot happening, but I didn't get it.
Okay, thank you so much. I missed the last part. I don't know whether it's my internet, but if anyone would like to comment and come in before I go to Christian.
I think as advocates in our countries, first and foremost, we need to advocate for government investment into this problem of us aging with HIV by providing necessary tests first and foremost. Don't only provide HIV drugs and viral load for HIV, but we need several tests as we age. Yeah, you need to know my liver, status of my kidney periodically. You want to know the status of my high blood pressure, so on and so forth. So we need to advocate for integrated services in our communities first and foremost. That's really very important to me. Thank you.
Thank you so much, Supercharger. I'm going to move to Christian.
I would just add
go ahead.
that, PEPFAR, Ambassador Nkengosong, is very aware of this, and he is really trying hard to expand services provided in PEPFAR to go into non-communicable diseases, so hypertension, diabetes, because yes, as we're taking care of populations living with HIV and as they're aging, we need to take care of the entire patient, not just their HIV.
True. There's before coming to Christian, there's also a question I think that is important when we start thinking around HIV, the intersection between HIV and COVID. And I think these are conversations that have happened quite a lot at CROI. And I was wondering if any of you would like to comment on that as well, because people want to know, is there any new data at all that is coming out? Christina or Carlos or Natasha?
There's not a lot of new data coming out. I think, one thing that there are a lot of studies, but most of them show that people living with HIV were not necessarily more severely impacted by COVID. That is, and that they respond well to vaccination. But I think that we're obviously, this virus is still with us, continues to evolve. I think where there's a lot of interesting data, and a lot of more concern to me more than with COVID. It's actually with Mpox, and Mpox is it's a new outbreak in the DRC with clade 1, and again, I think a mistake we made with COVID has been made with Mpox, which is we are not rolling out vaccines equitable, and there the risk of Mpox, severe disease, in people who have advanced HIV or uncontrolled HIV is very significant. So I'm very concerned about that intersection, and the fact that we seem to not have learned from our mistakes. We are not applying equity in accessing to drugs and treatment for and vaccines for Mpox.
Thank you so much. There's a hand from Christian. Over to you.
Wonderful. Thank you for a great discussion this morning. I specifically just want to speak about this notion of choice, whether it comes to prevention or treatment options. It is great that we have long-acting injectables and we have more options now. But sometimes when we speak about it, it sounds as though the onus is only on the consumer just to choose between these different options that we have. And I think we lose sight of the context. I was particularly thinking of the SEARCH trial results and looking at the high uptake of injectables in countries like Uganda and Kenya, and thinking particularly about men who have sex with men. Maybe they didn't feel like it was a choice for them to actually take oral PrEP because it's not very discreet, it can easily be discovered, but they feel like it is a choice for them to take injectable PrEP because of discretion. So then in that case, when we speak about choice, we need to contextualize that a bit better.
Thank you so much. I think I would like to go to Natasha. We haven't come to you in some time, and I want you to comment on the just last comment regarding choice. There was also a question I remember at the session around offering dapivirine ring, for instance, which we didn't get a clear response. What are your thoughts from that comment?
Yeah, no, I definitely agree with the previous speaker on the comment around really the definition of choice. Is it that in that moment, could it be that that's what, is easier for the end user, and in many ways? So choice to me would be that in that moment, if at all I'm at risk and I have an option of either the ring, injectable, or oral PrEP, and depending on my situation, if I want to be more discreet, if maybe my partner, I haven't shared this information with my partner, I would rather go for something that's more discreet and something that is long acting, of course. But when it comes to other options like oral PrEP, we know a lot of challenges that are associated with taking a daily pill. And that has come up many times. And I love that he pointed out as to, there was a high uptake when it comes to Cabernet. But I would say that some of the reasons would be because of its long-acting discrete nature. And, oral PrEP is great. And depending on one's needs at that particular point, they would decide to go for it. But it's not easy taking a daily pill. It's not easy to have to take an option that is highly associated with stigma and discrimination. I usually interact with the community, and many times they would say things like, why should I take a daily pill to prevent myself from taking a daily pill? And what that means is, why should I take oral PrEP every day to not take, ART for treatment later on in life? So it makes it easy to have the injectable PrEP as an option. But then again, every person at different stages of life has different needs. But what's just important is that all of those area of options are made available so that that person is able to choose what works for them in that particular time. So I love that there's so much innovation, there's so much research going on. And I think I keep on emphasizing that there's need to create to bring that access, to bring to give access to these products for people that actually need it. We may talk about how they've been developed, but are people actually accessing these products? And I think that's the conversation that we need to really focus on and emphasize on, and make sure that these products actually get to the end user that need them. But yes, choice is very important. We need a lot more options so that the end user can pick what suits, what best suits for them in that particular moment.
Wonderful, Natasha. There's a powerful comment in the chat box, and I just want to quote the exact wording in the way it's been phrased. And it says, "We can't have choices when options are out of reach." I think that's a very powerful statement to explain. Jim, you had your hand up. Let me come to you.
Sure. I actually just wanted to amplify that, and whoever posted that, maybe that was Adobe, much more succinct than I was going to make it. But I think I'm a big proponent of choice. I think we need things, all kinds of options, not just long acting either. I think we need short acting things. I think we need things that have varying efficacy, because efficacy is not the only attribute that people value. There's all kinds of things about choices and how they fit into people's lives, and sometimes something that has slightly less efficacy may be more suitable to somebody. So I like to think about how we can get out of this box of everything being efficacy, and long acting. Obviously, they're both very important things, but they're not the only things. And just to underscore, choices mean nothing if they are out of reach. Choices mean nothing if our countries aren't supporting them. Choices mean nothing if they're very hard to get. And I'll finish by saying, you know, in the United States, we have some choices. Long-acting cabotegravir is available technically in the US, but is it accessible? No, it is really hard to get. The average person, from the time they say they want it, may have to wait up to a month or more. And then they're at the mercy of pharmacy benefit managers and insurance companies who don't want to pay for it. It's crazy expensive. And all those things make it really hard. We may have a choice, but if the choice is associated with friction, with many hoops you have to jump, with many dollars you have to put out of your pocket to get it, it doesn't mean anything. So we have a lot of work to do to make choices become a reality, and then actually make choices that actually are things that people can pick up and use, and not go through a lot of drama to do it.
Amazing. So choice, the conversation is around choice in terms of HIV prevention. But I want to go back to Supercharger now. So you are a mentor. I think for this CROI 2024, you came in as a mentor, and you've worked with many community educators. If there were maybe 2 to 3 key messages that you're taking out to your community from this conference, what would those look like? I'll come back to the chat box, but I would love to just hear quickly from Supercharger on this as well. What are some of the key messages you're taking with you?
Quickly, before I give the key messages, I want to make this report, which I got from Professor Sharon Lewin. He had a presentation yesterday, but it was a bit discouraging to me as a cure advocate. They have discovered that actually the current latent reversing agents we have cannot work very well in the CNS. So to reverse HIV from the CNS, they either have to combine the current latent reversing agents or look for the next generation latent reversing agents. This is a big concern now that we are preparing to put folks off treatment in the ongoing studies. How are we going to do that when the latent reversing agents actually cannot work very well in the central nerve system? So that's a big concern. The key take I want to give to actually, I'm glad to be a mentor this time around at CROI, and it was really amazing to interact with these vibrant young folks, and I encourage them to to continue standing for the issues that really affect their communities. That's really very important. Even the researchers trying to find in new interventions start from us. They hear from us first, and then they say, hey, there is this problem, so let's begin the research. So if we don't raise these concerns affecting our communities, we are not going to be able to help our communities. I was a mentor and I had vibrant mentees. Can you give me just 1 minute? I want Towela to give just a quick 1 minute highlight of her, because we need to empower young persons. We are aging, as you know. The next 10 years, Supercharger will not have this energy you see right now today. It will be the Towelas, the Natashas, the Chiflias. So Towela, are you online so that you can give just a quick 1 minute highlight of this amazing conference? Yep. Towela, you are there? Okay, but as she prepares to come in, I must say they were really very vibrant, energetic, and we learned a lot. I encourage them. It's very, very important to ever take on the microphone. When we take these microphones in these conferences, we get answered. Because we come to these conferences with concerns and issues, and if you don't take that microphone up to raise that concern, the researcher will not know, the program policy makers will not know. So I encourage these young mentees always to stand up and take that microphone and raise concerns. Yeah, that's really very important.
Thank you so much, Supercharger. If Towela, if you're online, please raise your hand at any point. I think we'll come to you. But at this moment, I want to go back to Carlos. I think there's an important comment in the chat box as well that I would want you to respond to. So they're asking around your thoughts or perspectives around injectables for people with substance use disorder, for whom injections might actually be triggering. What are some of the science coming out or any research coming out?
That's what's going to be presented today in the Latitude study. Many of the participants in Latitude actually had substance use disorder. We did not see this as a trigger. But again, you need to be sure that people with substance use disorder who are, we need to provide them with access to treatment and to access to, so at the end of the day, we did not see this, but we need to ensure that we provide comprehensive care.
Thank you so much. I'm also seeing a comment from Jessica from AVAC. I think it's an important comment because of the conversation we're just having around cure. And if you are able to come off mute, I think we'd love to hear your thoughts as well.
Hi, Grace. Hi, everyone. Thank you for that. I just want to say, I think Supercharger is spot on about the need for a cure that's accessible and affordable. But I did post a link to the Treatment Action Group tracks clinical research, and latency reversing agents are just one of several strategies that are being explored by cure researchers. So I think just really important to put that into context and to see all the exciting progress that's happening in the field.
Thank you so much. I know time is running fast, but we're encouraging you to continue asking the questions, to continue engaging. I think there is also another comment, I think from Jeff. I don't know if Jeff, if you'd want to come off mute or on camera, but you have referred to social behavioral research and cure research. And I think that's an important conversation. On Monday, on the community breakfast session, we also had this conversation, the role of social behavioral research. So I just come in and comment on that as well.
Yes, thank you, Grace. I was kind of responding to what Supercharger was saying. I mean, none of these things will work if we don't have the buy-in from the participants. And especially in the context of cure, we're asking so much of people. There's no benefit to be in these trials. We're asking them to take incredible risks. Most studies will require people to stop treatment to see if their HIV treatment, to see if the cure intervention is working. So in that context, we really need to be talking to people, seeing if they're willing to do this, if we can even conduct the trial. And if we do, how do we protect them? How do we protect our partners when they're off treatment and have the risk of passing the virus on to their partners? There's so many important issues that have to be tackled before we even embark on these studies. So Corinne Dubé, I want to do a shout out to her. She's done a lot of research in this. Just Google her name. You'll find a lot of amazing research, and she's doing more. So thank you.
Thank you
And
so
a
much.
quick one as community, a quick one as community, we demand consensus on ATIs. We need a common global consensus on what should be done when, Grace, you are put off treatment. Do you take a viral load weekly, a week when you're off treatment? Do you take it monthly? I mean, you also need support. You remember people disappear for 6 months. Assuming you are put off, just imagine you are put off treatment and then you are supposed to report next week and then you disappear. What happens? We need to have tight programs that support these participants when they are put on off treatment. But you can't have that before you have a global consensus on ATIs. But I'm glad to say that as community, we are organizing a consensus meeting in Nairobi for this concern, ATI, which is analytical treatment interruption. Thank you.
Thank you so much, Supercharger. I hear, Toera, you are ready to share your experience and your thoughts. Just to emphasize again that Toera is a community educator, and this is her first CROI. So as we said, we wanted to hear from people who have never been at CROI at all. So it would be good to just hear your thoughts.
I'd just like to say this is definitely my first time being in this space. I'm very, very excited of being in this space. And I also am one of those young persons mentioned that is definitely advocating for my community here in the United States. I'm in the Jackson, Mississippi area, the state capital, where I'm definitely on the forefront trying to push for a lot of the things that we don't have access to, the barriers that we actually have as access to care is very detrimental in my community. And so I just applaud all of you for the work that you are doing. And I definitely like to be in close contact with each of you if possible. I don't know if we have a platform where we can share contact information to possibly be able to gain resources on things that are working in your different communities that might be able to be implemented here. That might could work for us. So it's definitely a pleasure, and thanks for having me in this space.
Thank you so much. So we only have a few minutes to go, and I want to give our panelists another opportunity. So I'll go around through all of them. So just to give us their final thoughts. Again, continue commenting. We might not be able to respond anymore. I'm seeing a hand from Francis. So maybe I can quickly come to you for just a minute, but then go to our panelists.
Oh, thank you very much, Grace. During our luminary session that we had with Dr. Shalom on Monday as community educators, just from personal experience, she underscored the critical importance of meaningful community engagement throughout the clinical trials, even from the brainstorming phase. So Shalom pointed out that some of the trials fail, often it is contributed to poor community engagement. So it was a rich information, our conversation that we had by that time. And I really wish that such personal experiences can also be shared with these new investigators that are learning, particularly during the plenary session. So I'm wondering if it's something that can be done, and I really suggest that moving forward, we really consider this, because during that session, it was only us as community educators. Yeah.
Thank you so much, Francis. Continue commenting, continue. As we said, these are going to be recorded and we're going to share. If we are not able to respond to all the questions, we hope that Jim will follow up on some of them at a later stage. But at this moment, I want to go around and really just get final thoughts from all our panelists. So we're going to start with Supercharger. Let's keep it as quick as possible so that we can manage our time as well.
Thank you so much, Grace. And first and foremost, let's comment about the presentation that was done around tuberculosis. The 2018 UN targets were not met. The 22 UN targets, again, were not met. We are still doing very bad, but we need to keep pushing. TB is still a killing disease in our communities. I want to thank the organizers for giving me this opportunity. It's really very, very, very big. good experience. Thank you so much for giving me this experience. And I'm happy to continue the discussion, especially on vaccines. We need vaccines, basically. We need vaccines. We have had so many disappointments with vaccines, but we need to keep pushing. But we need to balance the energy between vaccine and HIV cure, because HIV cure is showing much promise. And I'm glad that this time around, CROI has put more cure sessions. That's really amazing. Thank you.
Thank you so much. Carlos?
Yes, I would say that the one thing I would add, first of all, is wonderful to have so many people who are new to CROI. I think new investigators, new community, new members, because this is what we need. We need a next generation. I'm part of the old generation, and I started working in 1983 when HIV was starting, and now, we need the next generation who has new ideas and advancing the cure and the vaccine research. But I would also say that one of the most exciting things we didn't really talk about is the monoclonal antibody era. And with broad neutralizing monoclonal antibodies, we're seeing vaccines, cure, prevention all come together. And the science is very similar. And the research that is happening around understanding how monoclonal antibodies work, I think is going to benefit vaccine research, is going to benefit treatment, is going to benefit prevention, and is going to benefit cure research. So everything is coming together in an interesting way. And I would say keep your eyes on the monoclonal antibody work, because a lot of the really good science coming out of there will provide the breakthroughs to eventually have a cure, a vaccine, or both. Thank you.
Thank you so much. Christina?
Oh, thanks, Grace, and thank you for the opportunity to participate on the panel this morning. As a mucosal immunologist, I'm really excited for the upcoming session today on mucosal immunity to HIV. So studying the cervical vaginal microenvironment and how that can impact HIV acquisition, and also susceptibility prevention options, how that impacts. And I also wanted to point out, I had a great discussion at a poster yesterday about the impact of gender-affirming care on the neovaginal and vaginal microenvironment. So that's something I was really happy to see this year at CROI.
Thank you so much. Natasha, the young voice closing us off.
Thank you so much, Grace, and thank you again. This was a great discussion, so much insights coming out. And for me, I think something that I would just love to end with is just really to emphasize, and I will echo Francis's comment around really the community being in the center. Whenever research is being done, clinical trials, it is very important that communities are engaged from the get-go, so that even when we come in as communities, as advocates, we would have been engaged from the beginning, and it makes our work a lot more easier, even when we start talking about rollout and engaging the community in terms of uptake of the product. So it's just been a great experience and exposure, and I really do look forward to more community collaborations between scientists, researchers, and the community, because it's the communities that are asking the hard questions. I think in most of the sessions that I've been and attended, whenever a person from the community asks a question, more scientists would be, oh, I didn't think about that. So communities are bringing in a new perspective, and I think there's need to provide more platforms for community voices so that we all work together, because everything we do as advocates is about the community. Even with scientists and the researchers, it's about the community. So it's very important that we collaborate from the beginning and all the way through. Thank you so much, Grace.
Well said. Mitchell in the chat box has just summarized this session so wonderfully, putting together almost the whole conversation. So he says, develop options, deliver choices, break the silos, and build the next generation. I think I couldn't have said it any better than that. But really, just to say thank you so much to our speakers, to our panelists for really insightful conversation, and to all the participants for the questions, for the comments. It's really been amazing to see the conversation going on. And you can already tell that there's so much going on. We have our work cut out. From here, what happens? Because it's not just about hearing the research, but we are here as communities. How do we translate this to the communities? That's the important question that we need to live with. At this moment, I hand over to Jim to close this session off. Thank you.
Thank you so much, Grace. And Natasha, your closing comments were absolutely perfect and spot on. And with you as a young leader, it is so exciting see where we're going to go with the kind of smarts and savvy that you are displaying, and all of your colleagues on the community community educator scholars. So many of you so young and so brilliant and so full of energy and power. It's so inspiring. I want to thank again, like Grace, everybody for being here and for all our panelists. But can we give a special bit of love to Grace for moderating this session? This was a hard one, okay? Because it wasn't one topic, it was every topic. It was everything that happened at CROI and trying to get, and all the panelists did a damn good job too, frankly,